Ready? Okay, guys, let's start. So, good afternoon, everyone. So, I have 1 hour to talk about hyponatremia and DDAVP, and to be honest, this subject will take maybe like 3 to 4 hours to finish. So, I try to minimize everything and summarize everything to make it within 1 hour. So, I'll try to focus on most important stuff for hyponatremia and DDAVP. Hyponatremia, it's really big dilemma to every physician, maybe, like not only in our department, critical care, in nephro, in ER, in inpatient hospitalist, everyone has hyponatremia patient and they struggle how they treat it. So no, can we just like click? No disclosure for today. Objective for today, I'm going to talk about, as I said, like definition and treatment of hyponatremia. I'm going to talk about the overcorrection of hyponatremia and the most important complication for that, the osmotic demyelination syndrome. Then I'll go over physiology and mechanism of vasopressin and DDAVP and the use of DDAVP in hyponatremia. So that's my statement for today. I've seen only one case of osmotic demyelination syndrome, but I've seen thousands of cases maybe of hyponatremia since I started my fellowship, maybe like millions of cases since I was medical school. I don't know how a lot of physicians, they try to avoid to treat hyponatremia. They're afraid from osmotic demyelination syndrome. And the funny thing, the only case I've seen in the osmotic demyelination syndrome, the patient did not have hyponatremia even. The patient has like cirrhosis and alcohol. So, and it was incidental finding on the MRI. So let's back to history. The first case of hyponatremia, or first case of central pontine melanosis, which is the old name for osmotic demyelination syndrome, was found in 1959. It was reported on a patient with alcohol and malnourished. And in 1987, they started linking the hyponatremia to osmotic demyelination syndrome. And in the early like 1980, they start, until that time, they still want the guideline to treat the hyponatremia as fast as we can to resolve the symptom or to resolve the neurological symptoms. At the same time, they start linking the overcorrection of hyponatremia to osmotic demyelination. Until the mid-1980s, they start writing the first guideline of overcorrection, which was like less than half or less than 0.5 milliequivalent per day, not more than 12, or per hour, not more than 12 per day, and not more than 25 within 2 days. And since that time, there's a lot of guidelines. If you see, it's been changing a lot. Every year they change the guidelines, and it's because all depend on the case report. There is no like a huge or good study like to confirm what's the guideline for overcorrection, what the goal of overcorrection. And all these cases depend on the finding of osmotic demyelination cases. So I'm going to start with like very typical case in our ER, like 77 years old female. History of hypertension on hydrochlorothiazide, came to the ER, cough, shortness of breath, fatigue, found to have fever, hypotensive, tachycardia, and on the X-ray they found pneumonia, and the patient was confused. So it's a very typical case in our ER. Patient was seen by her PCP 6 months ago, and she started on hydrochlorothiazide for hypertension. Last sodium was 6 months ago was 140. And patient was treated in the ER for sepsis. Typically, they give her like 30 cc per kg. They start her antibiotic before even the lab results come back. And when the lab result, the initial lab came back even before she got the fluid. The sodium was 115. She's anion gap metabolic acidosis, lactic acid 6, creatinine 1.2, and glucose normal. And that's her urine labs. And so the physician decided to repeat the lab after finishing the fluid, and the sodium went up to 125. On physical exam, they reported as usual, unremarkable, looks eovolemic, so it wasn't really like hypervolemia or hypovolemia on the exam. So what's your diagnosis depend on that? If you think about like, what do you think? Anyone want to participate or not stand? So anyone want to answer? You can maybe rule out some option from the lab. For example, SIDH, it's possible. Patient urine sodium is 40. Urine osm is high a little bit, so you still can consider SIDH. Hypovolemia, hyponatremia. I know the urine sodium is high, but remember the patient on hydrochlorothiazide, so you cannot rule it out. Low salt intake, I would rule it out because usually low salt intake, urine sodium will be low and urine osmolarity will be low. Diuresis, you cannot rule it out, and psychogenic polydipsia, you can rule it out because the urine osm is high. So you can rule it out too, but still you don't know the diagnosis because you need further workup. It's really hard to answer this question from just like one set of lab without like intervention and remeasure the lab later. And what's your next step of treatment? I put multiple options, like giving DDAVP by itself, giving DDAVP with D5, or start the patient on half normal saline or continue on normal saline with DDAVP. Also, it's hard to treat. You can rule out some option, but it's hard to treat depending on the situation of the patient. So I'm not gonna go over the answer. I will go over the topic, then maybe we can go back to this question later. So hyponatremia, it's not disorder. It can associate with multiple disorder. It can be associated with a lot of things. Like it can be with hypovolemia, it can be with hypervolemia, it can be with cirrhosis, it can be with low solute intake, SIADH, medication induced. So a lot of things can cause hyponatremia, and it's the most common electrolyte disorder, most common electrolyte admission into the hospital. And usually treatment of hyponatremia depend on a few things, acute versus chronic, symptomatic versus asymptomatic. Still until now, the fluid restriction is the first line to treat chronic hyponatremia, but not always works. And in the last few years, they found like there is few medication can use also with treating hyponatremia, like tolvaptan, urea, and loop diuretics. You can also use for sure the hypertonic fluid. And all this, depending on the cases or like evidence-based, still really limited. So I put this classification. You can classify hyponatremia in multiple ways. You can classify about like the lab, moderate to severe. They mentioned it's severe if it's below like 125. As I said, acute versus a chronic, and it's depending on the duration. They call it chronic if it's more than 48 hours. You can say like symptomatic versus asymptomatic. And the most common symptoms, if patient has mild to moderate hyponatremia, usually they have like symptoms of nausea without vomiting, headache, slightly confused. Whenever they start having like severe symptoms, they will start having vomiting, they start being coma, cardiopulmonary distress, and coma. And the fourth part, you can differentiate between the hypotonic hyponatremia, isotonic, and hypertonic. And that's really important to differentiate between tonicity and osmolarity. Because in the body, we have a lot of osmol. We have like urea is osmol, glucose is osmol, sodium, alcohol is osmol, mineral, like a lot of things that can increase the osmolarity, but not everything can increase tonicity. Tonicity is, or the tonic is effective osmol. That means it has ability to take the water with it through the cell membrane. And the only tonicity there are like the sodium and the glucose. So when you have a patient with a high sodium, they are hypertonic, osmolarity always. But when you have a patient hyperosmolar, you can still have hypotonic hyperosmolar. You can still have isotonic hypoosmolar. So it's really differentiate. It's really hard to have hypotonic but hyperosmolar because the most important thing is the sodium. Most reliable things in the osmolarity equation is the sodium because multiplied by 2. Last thing we can differentiate it depend or classify depend on the physical exam, hypovolemia, eovolemic, and hypervolemic. And that's the less reliable things. I remember like 20 years ago in the books, they mentioned like it's usually like most of the books, they have like the volume assessment is the first thing to go over the hyponatremia patient. But I think nowadays it's the last thing. That's the algorithm that was published 2017. If you see, the last thing in the algorithm is go over the physical exam because they did 2 studies and it showed that the sensitivity of physical exam only 50 to 80% and the specific only 30 to 50%. So it's really hard to know what type of hyponatremia depends on the physical exam. So always I prioritize that go over the lab. Then at the last thing, I will go over the physical exam for the patient. And the most important lab, when you say like, I like to differentiate it that way, like hypotonic versus non-hypotonic. I like it more than like to be like isotonic or hypertonic. Hypotonic hyponatremia, that means is a true hyponatremia. But then non-hypotonic hyponatremia, it could be either pseudo with high lipid or high protein or hyperglycemia hyponatremia. And just to remember, hyperglycemia, hyponatremia is not pseudo. It's the true hyponatremia. A lot of people, they mistake it. They say like pseudo hyponatremia because high glucose. It's a true hyponatremia because The high glucose take all the water outside the cells and dilute the sodium. When you fix it, you fix the glucose, it will fix the hyponatremia by itself. So the first thing you look to the lab, you look to the serum osmolarity to know it's a true hyponatremia. Then the next step, you look over the urine osmolarity and then the urine sodium. A lot of people, they mistake with the urine sodium. When it's low, the urine sodium, they think it's the patient hypovolemia, which is not true because the kidney depends on the effective volume, doesn't depend on the regular volume. And the effective volume, that means the volume reaching the organ or the volume reaching the kidney. So for example, CHF patient or cirrhosis patient, clinically they're fluid overloaded, but they don't have enough effective volume going to the kidney. And those patients always, they have like low urine sodium. So having low urine sodium doesn't mean the patient has a low volume. And also there's a lot of things can interfere with the urine sodium. For example, diuresis, advanced kidney disease, sometimes the kidneys stop not able to reabsorb the sodium, so start having like high urine sodium. And I put two things at the end. One of them is the trial of volume expansion and the fraction excretion of uric acid. So trial of volume expansion, especially like in patient of SIDH, I heard a lot that if patient has SIDH, do you give them volume or no? And giving them normal saline, are they gonna drop their urine serum sodium or low? So they did this study on 17 patients. They were diagnosed with SIDH, and they give them the 2 liters of normal saline. And when they reevaluate their labs, and if you see like 10 patients of this patient, they have increased their sodium up to 8, and 6 patients, they dropped their sodium by 6 points. And if you look to the image, like the only thing to differentiate the two groups of the patient was the urine osmolarity. So patient with high urine osmolarity, they drop their sodium, and the patient with low urine osmolarity, even if the patient with SIDH 300 is acceptable to diagnose the patient with SIDH, but they still can, volume expansion can work for them and increase their sodium. And the reason there's phenomena we call desalinization. That means when they take the water from the sea and make it like drinking water, they separate the salt from the water. So that's technically what the kidney doing. That's because the liter of normal saline technically is 90 grams of salt with the water. So the kidneys start dumping the salt and keeping the waters. That's why if the urine osmolarity higher than the fluid you're giving, the patient start holding the water and dropping. For example, like normal saline osmolarity would be like around like 300 or 308. Even you can choose between like 2% versus 3%. I had a patient with the urine osmolarity around 800. And even giving them like 2%, they will still dropping their serum sodium. So you have to choose 3%. The other things we have to think about the fraction excretion of uric acid. A lot of like physicians, they measure the uric acid in the serum when you're thinking about SIDH, which is not wrong. But to do like fraction excretion of uric acid, it's more accurate. This study was done on around like 86 patients. And if you see, they separate the group between SIDH group and non-SIDH group. And looking to measurement of the uric acid in the serum was 3.3 in the SIDH group, but in the other group, they were always high, like 6, 8, and 6. But if you look to the fraction excretion of the uric acid at the bottom was 17, and the cutoff above 12 here. And the other group, they have like 6 and 6 and 7. Looking to the other table, like table 3, if you see the sensitive of the fraction excretion of uric acid was 86%, and the sensitive and specific 100%. But the serum uric acid at the end, it's only sensitive 83 and 65 and sensitive 76. So it's nice to check the uric acid in the serum, but it's nice to do also like the urine uric acid and the creatinine in the urine, so you can calculate the fraction excretion. It will be like more supporting the diagnosis of SIDH. So what's the most recent guideline for overcorrection? So as I said, most of the guidelines comes from study. They did multiple studies before, and most of the study they did, like when you correct by 12, you don't see cases of osmotic demyelination. But there was only one case found with the correcting by 9. That's why, and the patient has high risk of osmotic demyelination. I will go over the risk factor later. That's why they try to target less than 8. So, but increasing the serum sodium by 6, it's enough to resolve the neurological symptoms. But increasing the sodium less than 4, it can increase the mortality with post-op patient. So you have always to target more than 4, but 6 is enough, not more than 12, and not more than 8 in sick patient. It's a little bit complicated. We'll go over it more. So that's a guideline. There's a US guideline. There's a European guideline. I will focus on the correction rate part. I'm not going to go over everything. And as you see, the European guideline, they have limited only 10 per day, but we like to be more complicated. So we have like a lot of guidelines. If you see that. So minimum 4. You remember, below 4, you will be like high mortality. If patient has low risk for osmotic demyelination, you can do 10 to 12. If patient high risk for osmotic demyelination, you don't want to do more than 8. But we try always to target like 4 to 6 because 6 is enough to resolve the symptoms. It's complicated. Always try to do like 4 to 6. 8 is not bad answer. Even if you do 6 to 8 is enough. And the problem is when the patient show up in the ER, you don't know if he's high risk for osmotic demyelination or no. So always think the patient is high risk. And you don't know the patient is acute or chronic. Always assume the patient is a chronic. So again, I'm just going to repeat one more time. That's always for high risk, 8 or below. Normal risk, 10 to 12, but not less than 4. But 6 is enough. Okay, complicated. So osmotic demyelination is very rare disease, and usually symptoms start 2 to 7 days. So I've seen a lot of like when overcorrection cases, people they document that our patient doesn't have neurological symptoms. That doesn't mean anything because sometimes it takes 2 to 7 days to develop like osmotic demyelination symptoms. And usually like slow correction or re-lowering the sodium, it shows some benefit with animal, but it didn't show any benefit like or they didn't do any study in the human, let's say in that way. Some picture of osmotic demyelination. If you see like normal natremia or normal like praying, when acute hypernatremia, because the sodium will drop in the extracellular fluid, so all the water will go to the higher osmolarity part, and the patient brain will be like swollen. In the chronic hyponatremia, the brain start being adaptive to the hyponatremia status. They will start pushing the organic osmol outside the cells. They try to push like the solid outside the cells, so try to balance between the extracellular and intracellular. But then when you correct the sodium really fast in the chronic hyponatremia, technically you're shrinking the cells and causing this osmotic demyelination. And another picture or another theory that's astrocyte apoptosis can happen and cause like disruption of the brain, a blood-brain barrier, or even there is inflammatory or cytokine activation as well and causing osmotic demyelination. All these theories, like there is no clear answer. Symptoms is not specific. It could have like dysarthria, dysphagia, flaccid paralysis. It can be like spastic later. Can have like ocular symptoms or lock-in syndrome. So the risk factor, I think all our patients in ICU, they have this risk factor. Like low urine sodium, hypokalemia, alcohol malnourished, and advanced liver disease. We have a lot of these patients in our ICU. There is a study they did it in 7 hospitals, and they did with 1490 patients. With all these patients, they have serum sodium less than 120, and 606 patients they had overcorrection, and 8 of them they developed osmotic demyelination. But looking to the other cofactor, only 7 patients they had hyponatremia, 5 patients they have hypokalemia, and another 5 patients they have alcohol. So the risk factor not only hyponatremia, there is a lot of risk factor can happen. Even like patient can have osmotic demyelination without hyponatremia. So re-lowering the sodium or the treatment of overcorrection. The most important thing to start with stopping the agent causing the overcorrection. So if you have a patient came with a hyponatremia, you give them fluid, stop the fluid causing overcorrection, stop the tolvaptan. The next step, you're gonna focus on replacing the free water losses and stop the free water losses. And to stop the free water losses, to give DDAVP, that's the only approved medication to stop the water losses. And you can replace it as well. As I said before, re-lowering the serum sodium approved only in the experimental and in the animal study, not in the human yet. There's 2 cases or 2 studies. I'm not going to go over it, but it shows like re-lowering the sodium. They induce it, then they re-lower it again, and it shows like improved with mortality versus the other group. And the other study, they use also dexamethasone. Dexamethasone, it showed decrease the demyelination, but it didn't decrease the mortality. So what's vasopressin? And vasopressin, as you know, like it's a prohormone made in the hypothalamus. It's stored in the posterior pituitary. It can increase in two incidents, either hypovolemia or increase osmolarity in the body. Usually it takes around like 1 to 2 hours to be and stored. The plasma level less than 4, and its half-life around half an hour. And usually it's metabolized by the liver and the kidney. It has multiple receptors in the body, and the most important receptor is the V1 and V2 because we use a lot. V1, it's vasoconstricted. That's the way we use it as pressors. Because it will increase the calcium in the muscles and it will cause vasoconstriction. The V2 receptor is found in the kidney, in the collecting duct, and also it's found in the von Willebrand. So it's found in the epithelium cell and can increase the production of von Willebrand and factor 8. V3, it can regulate endocrine like neurotransmitter and can regulate the body temperature and the memory and also STH release. So how the vasopressin works in the kidney? So if you look at the right side is the urine, the left side is the blood or the capillary. In the collecting duct, there is a V2 receptor. So the vasopressin connect to the V2 receptor, activate the cyclic AMP and start causing phosphorylation of the aquaporin 2 channel, which is the water channel in the collecting. So it will start moving the water from the urine to the blood. The other part is just how the tolvaptan works. It's just blocking this receptor and preventing the reabsorbing the water. So as I said, the secretion or the producing of the AVP, it can be stimulated by two things, osmolarity and hypovolemia. It's very sensitive to osmolarity. Even increase 1% of osmolarity can increase the production of AVP. If you see this algorithm, normal osmolarity in the body 285 to 295. Whenever the patient starts drinking a lot of water, the osmolarity will start dropping. At the point of 280, I expect the vasopressin to be suppressed totally, to be like totally suppressed. And at the same time, I suspect the urine osmolarity to be less than 100 because the urine will start being dilute to make the patient like, or the patient start peeing more water to increase their osmolarity. And going with the osmolarity higher and higher, it will increase the vasopressin to suppress the diluted urine. Okay? And as I said, only 1% increase osmolarity, it can change the vasopressin production. Going back to the volume, it's less sensitive for that. And usually there is like baroreceptor in the body, and it can activate the AVP production. And you need to lose like volume like 20-30% to start having to have production of AVP. So kind of summarize, decrease 2% of total body water, you expect the vasopressin to be double. But an increase in 2% only in total body water, you will maximize suppression of AVP. But only and you need like 20-30% reduction of MAB to increase the AVP production. So AVP, it's hard to check, and because it's unreliable, unstudied, it can be bind to platelet, so you cannot measure it. But nowadays there's something called like copeptine. Copeptine is when you break down the vasopressin, can be break down to copeptine. So they use it as surrogate for ADH or for vasopressin. So you can measure it in the blood. We still don't use it in US yet. I think a lot of countries they start using it, but we're still not approved yet to be used here. So what's DDAVP? It has this fancy name. It's man-made vasopressin. I got a lot of questions when we run the ICU, like from residents. Like for example, like if the patient start him on vasopressin, is it going to affect their urine output? Or if the patient you give them DDAVP, going to affect their blood pressure? No, because it's DDAVP has 10 times works on the kidney. So it's not going to be as effective as the vasopressin on the kidney. But if you see in the other part, it has 1,500 less vasoconstrictor action. So it's never going to cause hypertension, giving DDAVP. And the DDAVP approved to be used in 1978 the first time, but wasn't for hyponatremia. It was for other medical problems like diabetes insipidus, bleeding disorder, and like nighttime urination or bedwetting in the kids. The first time it's used for hyponatremia was in 2008, I think the first case, and 2010 was like approved to be used for hyponatremia or overcorrection. Since that time, there is a lot of studies. Most of them, if you see, like most of them, they were like single case report about relowering the sodium with the hyponatremia. Not a lot of them, they have like a lot of neurological injury. I'm gonna go over a few of them, not all of, because most of them, there's just like one case. So to use DDAVP, there's three strategies. You can give it as proactive or reactive or rescue. So proactive, that's mean if the patient came with a hyponatremia, you give them DDAVP before you do anything else to prevent overcorrection. And always remember, when you give DDAVP, you're not lowering the you're not lowering the serum sodium. You have to do always like co-intervention with the DDAVP to increase or decrease the sodium. So for example, when you give DDAVP, sodium should stay the same. I mean, if you give like DDAVP and D5, the sodium should goes down if the DDAVP is working. And if you give like hypertonic saline with DDAVP, the sodium will goes up. So it's only like to minimize the urine excretion of water and to know what we're gonna do like next. That's a proactive, so giving DDAVP before you do anything else. Reactive, that's mean you monitor the urine output, you monitor the serum sodium increase, and you give DDAVP when you notice increasing in the urine output or the serum sodium. Rescue, you only give it when the patient above the target or if the patient having any symptoms. So they did systemic review in Canada. They reviewed 94 articles and 17 of them were including this study and has 80 patients. And 4 patients were admitted to the hospital with sodium of 125 and they used DDAVP. And they try to differentiate between proactive, reactive, and rescue. And 29 patients, they got proactive. That means they got DDAVP before the correcting the hyponatremia, then reactive, then rescue after the overcorrected. So if you see with the proactive, the serum sodium changed in the first 24 hours. The first line was only 7. And the reactive was 8.8, but the rescue was 15 because those patients, they're already overcorrected and they're giving them a rescue just to drop them down. If you see the last 4 lines, the co-intervention, with the proactive study, they always use the 3% of the hypertonic saline, let's say like maybe 2% or 3%, and it was used 100% of these patients. And the rescue, they always use the hypotonic fluid to drop them down. And the rescue is depending on the situation. If the patient needs more volume, if the patient needs to drop him more, they can use hypotonic as well. And let's see. Oh yeah, there is outcome here. In the middle, there is outcome. There is only one case of osmotic demyelination happened with the reactive group. If you see the MRI evidence of osmotic demyelination, it's only there is one case. And there's like a couple cases of clinical and one case on the proactive. So kind of discussion of this study. So the only case of osmotic demyelination happened in the reactive strategy. The proactive strategy was like very steady increase in the serum sodium. They didn't have any case of this osmotic demyelination, and it's really recommended for a patient who's high risk for osmotic demyelination. So it means like to give DDAVP at the beginning and give 3% and watch the serum sodium how it goes. And you can adjust that 3% depend on the serum sodium. Patient who is average risk for osmotic demyelination, you still can use the reactive strategy. It's still acceptable. But the problem with the proactive strategy, that means giving DDAVP before the treatment, it has been associated with multiple complications, was not assessed in this study. For example, like prolonged hospital stay, mortality, and also like you always have to do co-intervention with it. Without doing co-intervention or the patient drinking a lot of water, not doing fluid restriction, the sodium will drop more. This another study was done only on the patient, they used the proactive strategy. And they have like 25 patients they admit to the hospital with sodium less than 120. They give all the patients 3% and D5, and those are 20 patients. And if you see that the level of increase, the serum sodium was 5.8 plus minus 2.8, so it was reasonable in all these patients, and there was no adverse event in all this study for any patient. Another study, like just to compare giving DDAVP with or without DDAVP. And this retrospective observation study was done between 2004 and 2014 for patients with hyponatremia less than 120, 123. And usually the primary outcome was just to measure the change in the urine sodium less than 12 or less than 18 for 8 hours. And again, from these 1,500 patients, they give DDAVP only in 254, and they always like look into the outcome into mortality, length of stay. So if you see at the bottom, mortality was lower in the group of DDAVP, 3.9 versus 9.4. Even the length of stay was longer when the patient got the DDAVP, 6 days versus 5 days. And most of the higher stay patients, they were the proactive, giving that mean the DDAVP before intervention. It was 28 patients, and the length of stay, there were 8 days for those patients. Another study with DDAVP with hyponatremia and hypovolemia, 28 patients as well. All of these studies, they are like minimal number. It's hard to find like really huge study. And they use DDAVP in the group, and they didn't use the DDAVP in the other group. Interesting, they've used the group that got DDAVP, they have like higher overcorrection. But if you look at the chart, those patients, they have like starting serum sodium of 112 compared with the other group, starting sodium was only 118. So it's more with the severity. It's really hard to debate on this study. What's the side effect of DDAVP? The most common side effect causing hyponatremia. And usually it happens in the patient, they're using DDAVP for other reasons. For example, like elderly patient, they do like bedwetting. Sometimes they give them a dose of DDAVP at the bedtime to stop the bedwetting. Central diabetic insipidus, sometimes you can use the DDAVP. So most of these patients, they come with hyponatremia. And usually when they show up to the ER, the first thing the ER physician, they do, they stop the DDAVP and they start correcting the hyponatremia, which is the bad thing. Because stopping the DDAVP for this patient and start correcting the sodium will shoot up very fast. They did a study on 15 patients. They divided this patient between 13 or 2 patients. The 13 patient, they withhold the DDAVP and they give intervention, either normal saline 3% or 5%. The other group, it's too minimal. They continue on DDAVP and they use the 3%. But looking to this group, I remember, let's again. So 11 patients, they got 3%, I remember, and 1 patient got the normal saline. But if you see, 3 patients, they died, and the increase in the sodium was on average 30 per day, went up. And there was 10 patients, they had brain injury. So whenever the patient on DDAVP for other reason, don't stop it right away and treat the hyponatremia. Keep it, but then use the 3%. Because even the other group, there was like any injury with it. It's not specific study, but still like it's really a lot of complication with a smaller group of patients. I think that's the proposal after this study, like for the treatment. You should continue the DDAVP. You should do like fluid restriction and use the 3% to increase the sodium. I think that's it. Any question? Any question? Back to slides.
So from what I can
Stand.
I know, right?
No, it's
So,
good.
I guess there's a couple of questions. You know, I think we often find ourselves doing a reactive strategy
Most of the time they use it
for
here.
treating hyponatremia, which seems to be fairly reasonable.
Mhm.
It's sort of an equipoise between length of stay and all of these complications. But I think what's striking is that the data is based on very
Minimal, very like it's all case reports. There's no official like data.
Is there any plan within the nephrology world to actually do some definitive study to get our hands around this?
So hyponatremia cases we have a lot, but the problem is like having complication. It's rarely to see like complication, and most of the time nowadays they really strict treating hyponatremia and the overcorrection. So that's why we don't even like see the cases of osmotic demyelination.
Which is good.
Yeah.
So what I'm hearing then is that you would have to, in order to power it properly, you'd have to have lots and lots of patients in order to do a study.
So we can do study on differentiate between proactive and reactive for other things, like for example, length of stay, the rate of overcorrection, but it's hard to include the osmotic demyelination. It will be like only one case, two cases here and there. It's really hard. Like even the study they did on 1,500 patients, they had only like one case of the osmotic demyelination.
Yeah, so it's because it's such a rare
Yeah,
complication.
it is to start with. I think there is like 50 to 60 cases in the last 10 years.
So like when we get them to the ICU, they either had some sort of intervention in the ED or something like that. When you're on call, you're getting calls from the ED for that treatment. Are you guys recommending the proactive as well?
We do sometimes. We do sometimes depend on the severity. Like for example, if the patient like really low, and depend on the staff. Usually we round with like I've seen it most of the time when the patient like 105 below. Usually we give DDAVP regardless, because the problem is the ER never call you the first things. They do like their own intervention, then they would call you. We always get the call after the overcorrection, by the way. And without labs, without urine labs. Sorry, man. Yeah. Always remember, labs before the nephroconsul. Yeah. That's the first problem, because like most of the time in the ER patient hypotensive, they give fluid and then they measure the labs came back like after 2 hours. They call you, there's no urine lab until you check everything will take like 4 or 5 hours. So it's really, but sometimes let's say if they call me, they say the patient is sodium is 105 and they already give them like a couple liters of normal saline. I wouldn't wait for until the other year. I will give them the DDAVP right away. Yeah. Because most likely it's going to be overcorrected. It's not going to hurt. Like, as I said, it's all DDAVP. It should stabilize the sodium. It's not going to go up. It's not going to go down. Giving DDAVP, and usually it's very short acting. Like it works like, I think like 5 to 6 hours, not more than that. And by the way, like giving DDAVP, you don't anticipate DDAVP always will work. Sometimes if patient has AKI, it doesn't work properly. So always after you give DDAVP, you have to measure the urine osmolarity to see is it working or no, because sometimes it doesn't.
Yeah. So can you help me again, because I'm old and confused. So the case that you brought up was actually a very relevant one, sort of.
Let's go back to it.
Septic patient.
Yeah.
Because I think that's something that becomes challenging. We all kind of.
That's maybe typical patient.
You wonder how much fluid should I give? What should I be looking for? So
let's go over the case again. Yep. So if you see the lab, like high urine sodium, or from the beginning, like serum, the first thing I will look for the serum osmolarity. I calculate the osmolarity and I do the measure to see if there is gap. If there is no gap, that means a true hyponatremia. So it's hypotonic hyponatremia. There is no other reason. It's not going to be high glucose, not going to be high protein or triglyceride. I don't even need to check that. The other way to measure that, you can order whole blood sodium to know is it like true hyponatremia or no. So the next step, you check urine sodium and urine osmolarity. Urine sodium, it can tell you. I usually look to the urine sodium as ROS pathway, the renin-angiotensin activation. So if it's activated, that means the kidney trying to preserve sodium, or the urine sodium will be low. If it's high, that means it's not preserving. That means normal. So in any like liver patient, heart patient, hypovolemia patient, always the urine sodium will be low because renin-angiotensin will be activated. Then looking to the urine osmolarity, I look to it as ADH word. If the urine osm is high, that means the ADH is secreted. And remember, even in hypovolemia, the ADH will be secreted. So having high urine sodium, urine osmolarity, you can rule out low solid intake. You can rule out polydipsia. You can rule out things in the. So from the urine osm by itself, I can rule out the polydipsia. I can rule out the low solid intake, but I cannot rule out SIDH. I cannot rule out hypovolemia. I cannot rule out diuretics. So back into this, I can maybe like check the fraction excretion of the uric acid to differentiate SIDH from the other. It's also not 100% relevant, but still like we can do it as measurement. Giving the patient like 2 liters of normal saline and improving the sodium by 125, it can more support the diagnosis of hypovolemia, hyponatremia. As I said, SIDH can improve, but not gonna improve by like maybe like 10 with 2 liters. What else? Diuretics with the hyponatremia, most of the time when you have like hydrochlorothiazide, it doesn't really cause hypovolemia, but it can cause hyponatremia. It's different from loop diuretics. Loop diuretics can cause hypovolemia. And so it's hard to interpret, but what I would do next, I would, since the patient has overcorrection, since the patient is making urine, the most important thing to give DDAVP to stop the urine losses and replace it. So I would give the third option, DDAVP and like D5 bolus. And you can calculate like how much D5 you would like to give, depending on how much you want to lower the serum sodium. And usually I do it the same way we do like free water deficit, like the difference, to see like how much you want to give like to lower the sodium by this amount. So always you think like when you give DDAVP, you stop the serum sodium the same way, or like stop the kidney making your water. Then when you give D5, you to lower it. You can use the half saline if the patient is still to be hypotensive. You still need to give them some volume. It can lower it, but I will still use DDAVP with the half saline. Normal saline with D5. Depend, like if someone crashing, I still need to use, like I would worry about like the hypotensive and the shock status more than the sodium by itself. Yeah.
What was that? I was gonna say.
So it's a little bit complicated.
No, but I think it's a great example, right? Because this is something we commonly see in the ICU and we commonly struggle with. And so just going through that exercise puts it all into context and helps, formulate sort of a methodical way to approach it when you get all confused as to what you're looking at with the electrolytes in the urine study. So thank you for that.
Absolutely. Question? No.
What is the difference? Because I get residents always asking me, so I'm sure people are listening. What is the difference between a free water restriction and a fluid restriction?
Oh,
because that is needed in DDAVP administration usually.
Yeah.
So what is the difference?
So free water restriction, anything considered free water. Tea, coffee, juice, whatever, Gatorade is free water. Interesting, when you do free water restriction, the nurse doesn't restrict everything, by the way. I found out that like that patient is still drinking Gatorade because it doesn't consider free water. The patient's still drinking coffee and tea. Fluid restriction, that's mean giving him IV fluid also, like restrict that. Try to restrict everything the patient is getting. Try to avoid like multiple, like KVO, try to avoid like the fluid in general. So you have to control that. The nurse usually control the free water restriction. And there's two orders, by the way, like there's fluid restriction, there's free water restriction. In hyponatremia, always free water restriction. Because if the patient hypovolemia, hyponatremia, you still need to give them fluid, but don't give them free water. So any patient with hyponatremia, any type of hyponatremia, you order free water restriction, no matter what.
The other thing is, if you give fluids, like in this case that we have, you should monitor the urine output, because sometimes the patient will, if they were hypovolemic, hyponatremic, they will start jumping.
Yeah.
So that's sometimes I'm like, okay, how much is the patient urinating? And so if you notice that the patient has, please put a goalie in. That's usually because if they start dumping, they will dump a lot, and that won't be measured. Sometimes they'll be urinating really back all the time in journals, and no one knows actually how much is dumping. And that helps us out in terms of helping correct the sodium back down. So.
Yep. And one thing about like giving them volume in the SIDH, I forget to mention, always remember like sometimes you have multiple comorbidities at the same time. You're not gonna have like maybe sometimes like a pure SIDH patient. You will have like SIDH patient, chronic, he came with diarrhea, he has hypovolemia and SIDH at the same time. So you see like their sodium 115, you give them half a liter of volume, their sodium will increase to 120, then stuck at 120 and not going above that. Because they correct the hypovolemia, but they didn't correct the SIDH yet. So it's sometimes, most of the time they have like multiple things together.
So what I'm hearing is that you have to just keep reassessing and
Keep reassessing.
sort of
Giving the volume in SIDH patient, it's really nice to just check urine osmolarity. If the urine osmolarity like in 300 to 400, I would still give the volume. Because even like the ADH can be produced by osmotic and non-osmotic reason. For example, like pain, nausea, Like any like stress can increase the ADH production in the body from non-osmotic reasons. So giving some fluid can suppress that. Okay. Any more question? Okay. Thank you so much.
Thank you.
Albert?
Yep.